Welcome, welcome to today's congressional briefing, which is intended to examine the role that psychedelic drugs might play in ameliorating psychiatric illness, and this includes substance use disorders. We're also going to discuss barriers to research that are currently faced by those trying to do research with psychedelic compounds. So I'm Mark Resnick. I'm the vice chair of the American Brain Coalition, and I'm also a professor of physiology, biophysics, and psychiatry at the University of Illinois College of Medicine in Chicago, and a research career scientist at the Jesse Brown VA Medical Center, also in Chicago. So the American Brain Coalition, along with the American College of Neuropsychopharmacology, have partnered with Congressman Earl Blumenauer to host today's briefing. The American Brain Coalition, or ABC, is a nonprofit organization comprising the United States leading patient advocacy groups, voluntary health organizations, as well as providers, neurologists, psychiatrists, psychologists, and the researchers who do neuroscience the neuroscience of psychiatry. And ABC seeks to increase the understanding of brain function and reduce the burden of brain disorders to society. And we're doing this through public education, engagement with policymakers, and advocacy with both Congress and the administration, and you, the general public. The American College of Neuropsychopharmacology, or ACNP, is an international professional organization of leading brain scientists, and selected primarily on the basis of their original research contributions. And the membership of the college is drawn from scientists of diverse subfields of neuroscience, particularly as it relates to psychiatry. And so we do the neuroscience of psychiatry. Our members are consistently acclaimed as thought leaders in psychiatry and pharmacology. And Drs. Volko, Yehuda, and I are all members of that society. Congressman Earl Blumenauer represents the 3rd Congressional District in Oregon. He's a lifelong resident of Portland, and he was first elected in 1996, and he's been a member of the Ways and Means Committee, where he's promoted healthcare access and environmental reform. He's really a tireless champion for patients suffering from brain disease, and for those of us who are researching brain disorders and the brain, period. What we're hoping, Congressman Blumenauer is one of the founder and co-chair of the House Neuroscience Caucus and the Congressional Bicycle Caucus, and he sends his regrets because he's going to speak to us through video, but I guess he's ready to go. Congressman Blumenauer.
Greetings. I wish I could be with you today, but I've got some challenges with the vote schedule. But I want to thank the American Brain Coalition for the opportunity to speak at this important briefing. You know, everybody always says it's an important briefing, but this really is critical. And you know why. As the founder and co-chair of the Congressional Neuroscience Caucus, I've been a longtime advocate of supporting research for brain-related conditions. Brain disorders, injuries, and diseases affect over 50 million Americans. It costs our country more than $1.5 trillion annually. And this is the only major area without breakthrough treatments like we've had for cancer and cardiovascular diseases. One of the reasons is that treatments for brain conditions are more expensive to develop, more likely to fail, and they take longer to develop. I'm proud to bring Oregon's leadership on access to psilocybin therapeutic use to my work in Congress. A growing body of research shows the effectiveness of psilocybin, MDMA, and other psychedelics taken in consultation with medical and mental health experts for people who suffer from depression, excessive drinking, chronic pain, anxiety, PTSD, and terminal illness. It can help them. These promising advancements have been slowed because of the pace of regulatory approval that's been far too limited, especially for a naturally occurring substance that's been safely used by humans for therapeutic uses for thousands of years. It's clear that the federal government must be a better partner on the path forward so that we can see the results of promising research turn into effective therapies. That's why in January, I urged the DEA to allow terminally ill medical patients be allowed to access psilocybin under state and federal right to try laws. In yet another signal that drug reform doesn't have to be a partisan issue, several Republicans joined me in working with the DEA, as well as introducing the Right to Try Clarification Act, which would remove the FDA from the patient-doctor decision-making and clarify that states are the appropriate regulators. We need better education, understanding, and frankly, respect for the research that shows the potential these drugs hold for treating medical patients. Criminalization cannot continue to be the standard for substances like psychedelics. From critical uses, meeting the needs of those most impacted by antiquated drug laws, it's time to enact real reforms. And this is where you come in. The work you're doing demonstrates the effectiveness of psilocybin and psychedelics in medical treatment, and the need for legal reform is crucial. Oregon's leading the way on legalizing substances that should not be criminalized, instead regulated, researched, while promoting access to those groundbreaking treatments. In this process, Oregon is taking a thoughtful, scientific, and careful approach to building the infrastructure for psilocybin therapeutic use, providing a strong model we can use as a foundation for federal action. As we lead this effort across the country and at the federal level, your efforts will help build the momentum and support that is needed to move us forward. Thank you for your ongoing work on today's discussion. I look forward to working with you to make sure the federal government is a better partner in the work ahead.
Thank you, Earl Blumenauer, for being such a champion of people who suffer with brain disease and those of us who research the brain. And we're so proud to have you on our side. My notes say that the next speaker needs no introduction, but I'm going to introduce her anyway. And Nora Volkow has been, Dr. Nora Volkow is the director of the National Institute on Drug Abuse at the National Institutes of Health, or NIH. And NIDA is the world's largest funder of research in the health aspects of drug use and substance use disorders. Dr. Volkow's work has been instrumental in demonstrating that drug addiction is a brain disorder. And as a research psychiatrist, she's pioneered the use of brain imaging to investigate how substance abuse affects brain function, and in particular, how the areas of the brain involved, particularly in the dopamine system, involved in both reward and self-control, are altered in addiction. She's also really made many important contributions to the neurobiology of obesity, attention deficit hyperactivity disorder, and aging. Nora, the floor is yours.
Mark, thanks very much, and it's a pleasure to be here. And I do want to also thank Congressman Earl Blumenauer for his passion and leadership on moving forward treatments for individuals with mental disorders, and also for organizing this session, which is certainly from the perspective of pharmacology and neuroscience is incredibly fascinating. And so I'm going to share my screen, if that is okay with all of you. Let me get, and you're going to have to tell me if you see it or not. Okay, did you see it? Can you see it? Yes. Well, I mean, my presentation is going to be basically give you a short summary of what we know, what we don't know, and some recommendations on where should we be going. Psychedelics, and they receive different names. And there are different classes of drugs under them. So I think it's important to have a clarification. These are mind-altering drugs that influence physiological, cognitive, and emotional states. They do not produce dementia, and they do not, in general, have addictive properties. The only one that we know of clearly with addictiveness is ketamine. The ones that have generated the most recent interest have been the ones that are basically described under the classic hallucinogenic drugs. And that includes psilocybin, mescaline, LSD, the dimethyltryptamine, which is derived from ayahuasca. We also, on the other hand, know that of the dissociative drugs, ketamine has been shown and approved by the FDA for the treatment of depression, and it shows a higher efficacy than other treatments, and it also has the advantage of acting very, very rapidly. And there are others that have different characteristics, that have different pharmacological actions, but are also considered sometimes among the psychedelic drugs. In my presentation, I'm just going to be focusing on the classic hallucinogenic drugs. We have seen an acceleration on the use of psychedelic drugs for predominantly either recreational purposes, not because they are addictive and they produce the high or something like cocaine, but because of that change in state of consciousness that is sought by many in order to get new experiences. And you can see, for example, in this particular graph, what is happening as it relates to the use, not per se for recreational purposes, but for so-called therapeutic purposes. And we've seen a significant increase in the number of participants on clinical trials, as you can see in the left. And then on the right, you can see the number of publications that you can get if you just enter into PubMed psychedelic therapies. And you see how they have just jumped out starting towards in 2017, 2015. And this reflects, I think, the recognition of the fascinating pharmacological nature of these drugs. And obviously, there was a lot of interest on these drugs in the 60s, but we didn't have the understanding about how the brain works and the mechanisms by which these drugs may be acting that we currently have, nor about how the brain is organized and what are the processes that are necessary for our states of consciousness. That has advanced dramatically over the past 3 decades. And so it places us right now into a reconsideration and an understanding about these, as I say, very fascinating drugs. This fascination that we scientists have, I do have as a neuroscientist, has also captured the public. And so here I have data from Monitoring the Future that shows the changes in psychedelic use, in hallucinogenic use, by 2 age categories, 19 to 30, where you see the highest rates of drug experimentation and use in general for every type of drugs. And then also ages 35 to 50, where drug use starts to decrease. And you can see how dramatically they increase from 2019 to 2020 and 2021 for both groups of cohorts. And this is the period of the COVID pandemic, and is one of the fastest rates of increase that we have seen for any drug during this time period. And I think it reflects, on the one hand, the attention of the media on these drugs, but also the opportunity that people felt that they had with them to try to perhaps escape a reality that was very harsh and that secluded us very much one from the other. This is just purely speculative on my part. So what is it that we know about these classic psychedelic drugs or classic hallucinogenic drugs? We know that they have a common pharmacological target, and that is the 5-HT2A receptor. This is a receptor that is activated by serotonin. And there are at least 14 different types of receptors, and some of the classic hallucinogenic drugs, apart from activating 5-HT2A receptor, also activate others. But the common one is 5-HT2A receptors. And what we know is that these effects are crucial for the subjective experience that people have when they take them. We don't know if that is per se necessary for their therapeutic actions, but we do know that it is necessary for the experience, subjective of experience that people have. We know where they are located, and we know that their highest density is actually in the cortex, the external part of our brain. And we also know that their concentration is higher in the anterior, the areas of the brain involved with just processing, judgment, including areas in the middle here that are actually relevant for our own awareness than in posterior areas of the brain. And then there's relatively much lower content of these receptors in deep areas of the brain and very low concentrations in cerebellum. These receptors, we also know, are located in the predominantly glutamatergic cells. These are excitatory cells, and some of them basically projecting into subcortical regions. And the belief, again, is to ultimately, at this point, hypothesis-driven, that these cortical cells may be indispensable in producing the dissociative changes with this type of drugs. So what is unique about pharmacologically about these drugs? Like any drug, in some way that can be cocaine or it can be amphetamine, they produce an acute effect. And that acute effect occurs around 10 to 40 minutes after you ingest them, and it lasts from 12 to 12 hours. And it depends on what type of drug you are taking. What is unique about these drugs that you don't see with cocaine or amphetamine is that they have, after 1 or 2 administrations, they have long-lasting effects. And that's what's so very fascinating. That with 1 administration or 2 administrations, you can detect changes that have been reported to occur after 6 months, for example, when it has been applied for the treatment of anxiety or depression. So again, therefore, the very important scientific question is how do these drugs do this? So what are our hypotheses about how they do this? I mentioned that the agonism, the activation of the 5-HT2A receptors is crucial for that subjective effect. And overall, researchers have shown that that subjective experience that can be, for example, a mystical experience or transcendental experience that goes beyond your own consciousness is directly associated with a therapeutic benefit. As you see in the graph here, the stronger the mystical experience, the more dramatic the reduction in anxiety or depression. And an understanding, but that doesn't necessarily mean there is an association that they are causally linked. But it does highlight that they are likely to be relevant. And identifying ultimately whether it is or not this the target is crucial, because for us in the research field, we're interested in developing molecules that bind to that receptor with optimal properties that may minimize some of the side effects that you could get when consuming these classic psychedelics. But even more intriguing, and that's why I call these drugs fascinating, is how the hell are they doing these long-lasting effects after 1 or 2 applications? And again, this is hypothesis at this point. It is believed that the agonism at the 5-HT2A receptor is important, and that results, because these receptors are sitting in glutamatergic cells, which are excitatory, in release of glutamate and brain-derived neurotrophic factor, or BDNF, which then stimulates to the TrkB and mTOR pathway, which is a signaling mechanism inside the cell that ultimately results in opening up and accelerating what we call neuroplasticity changes, by which, for example, you can insert new receptors into the membrane, therefore making that communication much more efficient. But they can also trigger adaptations in the morphology of these neurons such that they become much more complex. And this has been documented in animal studies. The question is, as of now, nobody has been able to actually show categorically that these neuroplastic effects from hallucinogenic drugs are necessary for therapeutic efficacy. We're assuming that the pyramidal glutamatergic cells in the cortex are involved, but we really do not know precisely if that is the case or particular cells are necessary or not others. And particular cells with what type of projections, what circuits are involved in the brain for therapy. And two, how do we know? Because in the whole concept of neuroplasticity, the question is, are there critical times at which these changes need to be made? And very importantly, Because when you open up, as it's being postulated, neuroplasticity, when you accelerate it, allowing for the brain to strengthen connections faster than it normally does, could you also in the process result in maladaptive plasticity that could have very negative effects to the individual. And therefore, the importance of understanding these drugs properly so we can use it to achieve maximal positive effects and minimize negative reactions. So what are the challenges that we face in doing research with these compounds? And there are major changes. And I think that Mark already alluded to the fact that in order to be able to do these studies, you need access to the drugs themselves. Unfortunately, for researchers, this is very difficult because they are Schedule I substances and therefore regulated by the DEA and FDA. So if you want to do research on them, you have to get a registration, and that process can take at least 1 year to accomplish. So it's much more complex than doing research with other substances, and that has become a major impediment. But assuming that you do have the drugs now and you can go ahead and do it, one of the major challenges in understanding and carrying on randomized clinical trials, particularly for drugs like psychedelics, where the expectation of the effect is likely to have very, very strong effects, how do we control for that? How do we generate, in other words, a placebo when the effect is so powerful? And when the therapist itself, because these drugs have to be given in presence with a therapist and someone else throughout the whole process to guide them through the psychotherapeutic intervention done under the influence of these drugs. How do we placebo that? And that has been a major challenge, how to do it. And there are recommendations that have been made. And I suspect as we go along, that there will be guidelines on how to optimally control for these aspects. But another element that we need to consider as we move forward with this research on clinical trials is, as we're doing these clinical trials, we have to think ahead and say, well, how are we going to translate these particular findings that I'm doing on this randomized clinical trial to be pertinent into a clinical situation? What are the active ingredients that I need to ensure such that I can get the benefits that I'm, for example, assuming you get them, encountering in my randomized clinical trials? These interventions emphasize two things: that my own mindset of the individual, the state at which I am, and the setting, which is the supportive environment. And your responses can be modified based on these two factors, set and setting. So what are the optimal set and setting conditions in a clinical practice? And how important and how do you then guide characteristics to ensure a rapport with a therapist that minimizes any negative experiences? And an area that I'm also very concerned about as we think forward, because I think we have to be proactive, these are very intensive trials. You can get one or usually two interventions that actually last 10 hours, and you have a setup like the one that I'm showing in this picture. And then the individuals have to be screened beforehand very, very carefully and follow up very carefully. That actually is going to limit access to this therapy to those individuals that have resources. And we need to think and figure out how to make these type of interventions equitable. So what are the conclusions? There are already randomized clinical trials that support the efficacy of MDMA in the treatment of PTSD, and you're going to hear specifics about this, but also on the use of psilocybin for the treatment of depression and cancer-related anxiety. The evidence for LSD and ayahuasca for therapeutics is very preliminary. So based on this finding and our knowledge of pharmacological effects of these drugs, it's absolutely justified and actually support expanding research on psychedelics for potential treatment of psychiatric disorders. And in this context, it is going to be crucial to have access to psychedelic drugs. As I say, these are Schedule I for research purposes to facilitate access to these drugs. At this time, the evidence does not support use of any of these drugs for patient care outside the research setting. Concern is, and actually is, the premature use of these psychedelic drugs, which could have potential negative effects. And this is of great concern because on the one hand, of course, we want to provide therapeutics for people with mental illness, which are very, very vulnerable. But that vulnerability makes them also more likely to fall in the hands of improper therapies that could harm them long-term. So I thank you for having me here, and I look forward for your questions. Thanks very much. And I'm going to stop sharing at this point.
Okay, and I'm going to start talking. Nora, thanks so much for your illuminating presentation and for auguring for the importance of continuing to do research on psychedelics and hallucinogens and how and if they may be helpful to all of us. So thank you. Before I introduce our next speaker, I wanted to remind those of you in the audience that we will have times for questions and hopefully answers, and that it's important that you insert those questions in the Q&A box at the bottom of your screen. Okay, and it's following the presentations, all of the panelists will all participate in answering. So we're now going to hear from Marcus Capone. And first of all, I'd like to thank him. He's speaking to us from Paris, where he's interrupting his vacation to be with us, and we will all appreciate this very much. Marcus is a former Navy SEAL. He's a founder and chair of VETS Incorporated. Mr. Capone medically retired after serving 13 years and multiple combat tours with the SEALs, where he served on an elite counterterrorism unit. Marcus received a bachelor's degree from Southern Illinois University, Carbondale, and a master's degree in global leadership from the University of San Diego, and an MBA from USC. My son Elliot met Marcus at a wedding a few months ago when we were beginning to plan this, and he said, "Dad, I met the veteran that you need to anchor this presentation. He's incredible." In the conversations I've had with him, I think you will agree. And now let's hear his story.
Yeah, Dr. Resnick, thank you so much. Just humbled to be here today. Katie Sale from American Brain Coalition, Dr. Yehuda, Dr. Volkow, always humbled to be around and in your company. Thank you. I am Marcus Capone. I'm co-founder, chairman of VETS, that's Veterans Exploring Treatment Solutions. It's a 501c3 organization dedicated to ending veteran suicide through the safe clinical use of psychedelic therapies. I'm also the founder of Tara Mind. It's to further expand greater access to these life-saving medicines and really to be able to meet the overwhelming demand we're seeing at VETS. As Dr. Resnick mentioned, I served 13 years in special operations as a U.S. Navy SEAL with multiple combat deployments to Iraq and Afghanistan. And I am extremely proud to have served this nation. And there's nothing at all that I would change about my time in service. But why we're here and what does need to change, however, is access to effective life-saving treatments for addressing the invisible wounds that so many of our nation's veterans are facing today. Having tried, I don't want to say every, but many available options that were offered to me to include multiple mood stabilizers, antidepressants, brain treatment centers, 5 in total, and a host of other evidence-based modalities, I can say unequivocally that psychedelic-assisted therapy saved and changed my life forever. Over the past 4.5 years, I've seen it save the lives of countless friends, teammates, colleagues, and others. I've seen it work for strangers and close confidants alike. I've seen it work for veterans with recent suicide attempts who are now living productive and thriving lives. I too was extremely skeptical about this sort of intervention, I was a lifelong multi-sport athlete. I was a collegiate quarterback, and I was a United States service member. I didn't, quote, do drugs, and I didn't associate with those who did. The only connotations that I heard about psychedelics were bad. And so I assumed that to be true. But the more I read, the more I learned about the history of these therapies and the efficacy of therapeutic use with the proper mindset and medical setting. Despite promising research in the 1950s and 1960s, these substances were banned and research was halted with the introduction of the Controlled Substances Act in 1970. Only now is the promise of psychedelic therapy reemerging after losing almost a half a century of research and data collection. Psychedelic therapy is the next major breakthrough in mental health care. With the proper set and setting and under medical supervision, these therapies will save not only veteran lives, but could save and impact American lives across our entire country. As a nation, we've become numb to the number of veteran suicides at roughly still 20 per day. This is absolutely unacceptable. No one needs or deserves the interventions more than our nation's veterans. It is unacceptable that the generation of American soldiers that has carried the weight of 20 years of sustained combat, lost countless friends in battle, and survived the wars themselves must return home to a new war they must fight alone, one which often ends in taking their own lives. As research continues to emerge, it is indisputable that these therapies are more effective than conventional treatments currently available. We are racing against a cruel and relentless clock as we lose almost 1 veteran per hour to suicide. We desperately need more research around psychedelic therapies, especially within the veteran population, as we are frequently excluded from current trials due to various comorbidities. My colleagues here will back that up. Research followed by legislative change will take years, if not decades, and during that time, we can lose over 100,000 more veterans to suicide. 100,000 lives, lineages, families, futures, sons, daughters, fathers, mothers, brothers, sisters, and friends. In perspective, we lost just over 7,000 fighting the global war on terrorism since September 11th, 2001, and we have now lost over 30,000 to suicide during the same time period. The fallout from suicide is final and far-reaching. Veteran suicide is leaving a lasting stain on the fabric of our nation, and as a nation, we can do better for those who have served our country. We must do better. I consider myself to be living proof that psychedelic therapies are undeniably efficacious when delivered in the proper therapeutic setting. In fact, I was so compelled by their superiority that my wife and I founded an organization, VETS, Veterans Exploring Treatment Solutions, to assist other veterans who may be in need of this same intervention. What began with helping my friends and former teammates has now begun to reach around the globe, with veterans, officials, and organizations from other countries reaching out to us on a consistent basis. Veterans from across the United States and now the rest of the world are becoming interested in psychedelic therapies at a rapidly increasing rate. When pairing the trust that exists within the veteran community, a need that is so great, and the therapies that are so incredibly efficacious, it creates a demand that is nearly impossible to meet. At VETS, we receive hundreds of applications on a monthly basis from veterans who are desperate, many on the brink of suicide. And although we are closing in on helping 1,000 veterans to date, we will never be able to meet the incredible demand on the front lines of this battle. Only legislative change will accomplish this feat. As we work relentlessly at VETS to send our veterans abroad for access to these therapies, we must advocate stateside, right here, for access within the borders of our nation, the nation we so bravely chose to defend. Never has our nation asked from a generation of soldiers than that of the post-9/11 era. This group of individuals has selflessly answered the call time and time again, deploying forward for 20 consistent years of intense combat and operational tempo to return to a staggering lack of meaningful interventions within the United States. Let's step up now for the generation of soldiers who stepped up for this nation following the horrific attacks of 9/11. Let's see the science. Let's consider new things. Let's show them that we honor their service and we deeply care about their sacrifices. 4 years ago, I didn't have much hope left. I'd been prescribed numerous pharmaceuticals, which caused undesired side effects and prompted more prescriptions to be written. Some of these medications had side effects of suicidality. Why are we fighting veteran suicide with medications linked to suicide? Today, I'm living a happy and productive life. I'm reconnected to my family, and I'm excited for the future. I take 0 prescription medicines, none. I found purpose again in our work at Vets as we make massive strides in changing veteran healthcare. I attribute this entire turnaround to psychedelic therapy. My treatment outside the borders of the US in a country where it was legal. And that happened on Veterans Day, ironically in 2017. On behalf of all veterans who may be running out of hope and running out of time, I invite you to assess the research, speak with the researchers and clinicians, listen to the stories, and take a chance in leading the way for change. Please join us on the front lines of this new battle, a battle that can be won, a battle that is not red or is not blue, one that doesn't have a side of the aisle, a battle that might actually bring a sliver of hope to our nation. Thank you for your time. Thank you for your leadership. Ultimately, you hold possibility for change. Thank you.
And thank you, Marcus. That was really inspirational. And I wanted to say that many of us in the biomedical sciences are resolutely anti-war and peace activists, but we are unconditionally pro-veteran and want to do everything we can to make your lives better.
Now, I'd like to introduce our last speaker, Dr. Rachel Yehuda. She's a professor of psychiatry and neuroscience of trauma at the Icahn School of Medicine at Mount Sinai. And she's also director of mental health at the James J. Peters Veterans Affairs Medical Center in the Bronx. Dr. Yehuda is a recognized leader in the field of traumatic stress studies. She's authored more than 500 academic papers, chapters, and books in the field of PTSD and intergenerational trauma. She's also worked on cortisol and epigenetic mechanisms and really really revolutionized our understanding of the neurobiology and treatment of post-traumatic stress disorder. Rachel is also a member of the National Academy of Medicine of the United States, having been recognized for these works. And I guess the thing I'd like to say most is that if I think of post-traumatic stress disorder and a single scientist comes to mind, that single scientist is Rachel Yehuda, and now you will get to hear from her. Thank you.
Thank you very much. It's a real honor to be here speaking with Dr. Volkow and Mr. Capone, and thank you so much for organizing this session. And I guess I'd just like to offer my perspective as a researcher who's currently doing this work in an academic and community setting. We're performing a large randomized clinical trial of MDMA-assisted psychotherapy in combat veterans with PTSD at the James J. Peters Bronx VA. And we're just about to start a study on psilocybin for PTSD at the Icahn School of Medicine at Mount Sinai. And these activities are part of a newly formed center, which involves multiple activities at both of these affiliated institutions. And I want to talk about just two things to build on what has already been said by Dr. Volkow and Mr. Capone. First, what motivated me to do this work? And second, what it's been like to do this work. And both points are going to be connected to really the central idea that's been running through this hour, which is that psychedelic-assisted psychotherapy is really promising for mental health, particularly for trauma-based conditions like PTSD, and we really need to be studying it. There's enormous interest. We all know that. There's enormous need. That's true too. There's what we haven't talked about yet is that there's been a lot of financial investment being made in industry. Veterans, as you've heard, and other patients are taking matters into their own hands to seek these treatments out wherever they can, however they can. But the state of the science is such that there really aren't a lot of clinical trials on psychedelic-assisted psychotherapy and mental health, but there are just enough to take a risk on it. There's just enough to make sure that we have a good investment in the future to do more work. Because without the science, we will be missing an important scaffold. The government needs to be involved to rectify this. I think it needs to incentivize the research and make it easier to do so that credible researchers can deliver objective data. So what motivated me to switch gears after doing mostly research on the neurobiology and epigenetics of PTSD, and to some extent investigating more conventional treatments in PTSD? Well, in some measure, it's because of testimonies such as what you've heard from Mr. Capone. I haven't heard people speak so passionately about a treatment approach and offer compelling evidence about how restorative and important it was for them, not only in terms of suppressing or reducing symptoms, but giving them a new way forward such that they want to devote their lives to making sure other people get this too. That's really impressive, and it really moved me. Our current approaches in mental health, not only PTSD, but also depression, anxiety, addictions, they fall short for many people, for too many people. And this, of course, is not new information, and you don't have to be a mental health researcher or a clinician to know that we all have a loved one with a mental health problem, and we know the struggles. Medicines like antidepressants are designed to suppress symptoms, not deal with causes or underlying processing of trauma. And some medication treatment lasts for years or decades and bring about side effects with symptoms reoccurring when the treatment is stopped. Now, psychotherapy can be very effective, but it can also be very distressing in persons who have experienced very significant trauma, and particularly in our veterans, because things having to do with combat and moral injury can be very, very difficult. So what's being offered by psychedelic-assisted psychotherapy is a process in which a psychedelic medicine can occasion an insight, self-compassion, and an increase in interpersonal trust with the therapists. And that allows the patient to approach difficult material in a new way. And so the psychedelic itself is not magic, despite the name magic mushroom. Rather, it facilitates the very process that has always been the cornerstone of mental health treatment, which when we talk about combining medications with therapy. And preliminary data are something to get very excited about. So now I'd like to share my screen and just show you that for a moment. Okay, so first, psychedelic-assisted psychotherapy. I want to show you that the psychedelic is a catalyst of a process facilitated by an ordinary state. And Dr. Volkow talked about set and setting, and how are we going to make our institutions conducive to doing this kind of work? Well, I want to just show you this picture of what we have set up at the VA. We have a parallel room at Mount Sinai, and it's basically just one room. And on the right-hand side is the journey. You can see 2 chairs for the 2 therapists. This isn't, of course, a real session. And then an integration area where you do the psychotherapy. So during the psychedelic journey, the non-ordinary state promotes an insight, but the healing occurs over time as the experience is integrated by the trained therapists over several psychotherapy sessions. So in an MDMA course of therapy, the medicine is only taken a few times. Usually it's about 3 times once a month for over 3 months. But in between our 12 90-minute sessions where a lot of therapy is occurring, and that's very important. Now here I'd like to just show you some results of this meta-analysis review by Fiducia and colleagues that shows the effect sizes for PTSD, medication therapy. Here you could see the antidepressants, and it's a small effect size, small to medium. For cognitive behavioral therapy, what you could see is a large effect size. But when you talk about MDMA-assisted psychotherapy, which is really combining a medicine and psychotherapy, the effect is much, much larger. And this is based on the phase 2 trials that were conducted by MAPS. And a meta-analysis of those 6 trials led to this following graphics that's summarized by Mithofer and colleagues that show that even after a long-term follow-up of most of the patients that were studied, and here you have 100 over 6 trials, about 2/3 of them no longer had PTSD a year after they received the MDMA. And so that is pretty amazing. I'm going to show you just one other slide. This is my last slide. And here you see graphed the results of the first phase 3 trials, the only phase 3 trial in psychedelics of MDMA-assisted psychotherapy for PTSD. And this was published in Nature Medicine last year. And what you can clearly see here is in the red, the group that received MDMA-assisted psychotherapy had a significantly greater response than the group that received the placebo therapy. The placebo response was still strong. They received the same amount of psychotherapy. But a few months after this study came out, and you could see the N here is 89 patients, a very large study came out by Schnur et al., where they randomized 990 combat veterans in the VA to receive either prolonged exposure or cognitive processing therapy, which are the 2 mandated treatments at the VA. It was a very large effectiveness study. And their point that they made is just in the yellow and the green. This is not a trial comparing these therapists. It's just exploiting the fact that they both use the same outcome measure, which is the CAPS-5. What you can see here and what they concluded was that both of the gold standard psychotherapy treatments do result in a significant reduction of symptoms. But when you overlay this plot against the Nature Neuroscience data for MDMA, you clearly see that MDMA is superior approach. But the most fascinating thing to me about these 2 studies, when you think about them together, is that the dropout rate for the MDMA was very, very low. But for prolonged exposure and cognitive processing therapy, about half of the veterans at the VA, this trial was done at the VA, dropped out of care. So there's something very important about being able to have a treatment that people might stick with. Now, as good as these preliminary results are, we need more studies. What I showed you wasn't data from a lot of participants, very large effects, but there's more to do, and there are a lot of unanswered questions about who this treatment's for, who it isn't for, how long it lasts, how will psychedelic-assisted therapy work in the brain, for whom it will work, what kind of training do people need to facilitate these treatments, how much psychotherapy is actually needed. And in some ways, people have a very good sense of security in using these compounds based on a long history of plant-based psychedelic use in sacramental work or for self-exploration. But I think we need the science that will help us explain how to use these tools specifically in mental health and what happens when we do. And we're here doing this briefing in part because getting that information that consumers need is going to be very difficult if Congress doesn't use its bullhorn to make things easier, to liberate resources for the work and use the already in place peer review process to vet the work. So right now, Research is completely in the hands of industry and private funders, and I have only gratitude for both industry and private funders because we wouldn't be here without them to force this issue despite the scheduling status of these drugs, and especially philanthropists who have really enabled research to where it is. But the NIH, VA, and DoD funding are cornerstones that drive evidence-based science and drive academic careers from the highest level researcher to those that are just developing as investigators. So it's government grants that lubricate the research ecosystem because they appropriately incentivize academic institutions to facilitate the needed work and provide the infrastructure for it and take care of the investigators. So government needs to get involved, maybe by partnering with industry and philanthropists. This will ensure that there's sufficient scientific groundwork, and if not, new wheels will be invented outside this process that has been established to vet new treatments. So the NIH, VA, and DoD exist to be able to do this work, but so far haven't contributed at all to designing, funding, or interpreting the results. So now I'm going to make my second point, what my experience has been like. I'm no stranger to conducting clinical research and doing things that are even very difficult and long. But the process of setting up this research, as Dr. Volkow alluded to, was really something, requiring multiple approvals, IRB, FDA, DEA, BNE, then going back again. And all of these approvals have to be obtained serially, not in parallel. And it was long and cumbersome. And it took more than 2 years to get the MDMA trial up and running. And getting local buy-in was interesting too. As you might imagine, most people in conservative academic settings and community care don't know that much about psychedelics and think they must be dangerous because they're illegal. At least that was the case a few years ago when I began. And as you may know, caution in the name of risk avoidance in government and conservative institutions sometimes translates into inaction or delay. And some of the logistics were daunting too. We had to get a 700-pound safe with security cameras and set up and design very different clinical space, conducive to the psychedelic work, train therapists, work with pharmaceutical sponsors who have their own constraints. And in our case, since we care about investigating the mechanism of action, also towards a personalized medicine approach to psychedelics, had to establish a lot of different biologic protocols and get simultaneous approval to run them with the trials. And we had to raise millions of dollars through philanthropy to conduct these trials over the next several years. We had to ask donors and foundations who care about mental health and veterans to take a leap of faith that we would get this done. But here's something really interesting. After we announced the opening of our MDMA trial for veterans, which I did on my personal Twitter account, more than 100 veterans contacted us to be screened in the first month. This is unheard of in my experience running trials or my experience running anything. Numerous non-veterans have also contacted us with stories of how they tried multiple therapies and wish to try psychedelic-assisted therapy as their last hope. And they want to do it legally, and they want to do it safely, and they want to do it with people who know what they're doing, that they feel comfortable with. So that's why we're here, to see if we can somehow make this easier, to be honest brokers of critical information. The government needs to get involved here and not just stand by. And I'm so grateful to my local VA leaders for understanding our responsibility to our veterans, and for Mount Sinai for similarly understanding the need to explore these treatments in community mental health. We started this a few years ago when it wasn't so talked about. Mental health is too big a problem. If it affects us, it affects us all. And if there is a potential solution, we have to explore it, and we have to partner with you. Thank you.
Well, Rachel, you certainly lived up to the billing. Thank you so much. Now we have some time to hear from everyone in the audience, and we have questions, or at least a few questions, that hopefully can be answered. What I've done going through the Q&A is tried to, there's some overlap. So I've tried to summarize them. And the first question is, so how do we fix it? How do we move these compounds from Schedule 1? What is there a role for NIDA? Is there a role for the VA? Is there a role for veterans groups? And is there a role for everyone who's listening? So each of you, please chime in.
Then I'm going to jump in. Absolutely, there is a role for NIDA, and there is also a role for NIMH, and there is also a role for NINDS and the Alcohol Institute. I think that it behooves us to take these drugs and investigate them, because actually the data is showing that there's an enormous amount of interest, and some of it is very, very promising. And so we want to be able for patients to know how to optimally utilize it and to minimize the likelihood of what usually happens in situations like this, that all of a sudden you have all of these treatment providers that are offering these hallucinogenic drugs with no oversight for quality control and no oversight for outcomes. And that could be very detrimental, because there have been instances of suicide and there have been instances of psychosis. And an improperly given drug to someone that may have not met the necessary inclusion criteria could derail what appears to be an extremely potentially powerful tools for therapeutics. So we need to ensure that we minimize the likelihood of adverse events happening outside the context of good clinical practice. But from the perspective what we're doing, and Yehuda was saying, the notion of the government needs to get involved. We are involved. We are funding researchers to do actually studies to evaluate from the NIDA perspective multiple things. We're involved on getting them in investigating their value for the treatment of addiction. We're involved on understanding the mechanism by which these drugs produce their effects and providing alternative molecules. And we are involved specifically with requests for interactions for development of products that can take advantage of industry. So we are using all of the mechanisms, and I do know for a fact that similarly NIMH is also, as well as the Alcohol Institute, are also very interested on expanding this area of research. We're also very sensitive about the difficulties of doing research, and we want to use our platform as science agencies to put pressure so that there can be easier access to these drugs, so that researchers can be able to do the studies that are needed in order to optimize potential benefits. So that's my answer. Yes, government is getting involved, certainly at the NIH level.
And the VA or veterans organizations?
Well, we just heard Yehuda, and I'm not going to be speaking for the VA,
Yeah,
but
no,
was
that's,
thanking them.
my eyes are going in these directions.
I am not speaking for the VA.
Nor am I.
But we did just submit a VA merit, and we will see how it does. I think you're right in that nothing prevents people from submitting grants. When I first started a few years ago, and I did talk to people at the NIMH, at the VA, and the DoD, I was told it's too early, let's wait for one of these compounds to be FDA approved. I think that the enthusiasm has really accelerated and been amplified since then. And so I think the best thing to do is for investigators to write these proposals and see how the peer review process deals with it, see what kind of scores they get. But again, the average investigator is going to have a hard time in these compounds.
Well, my merit renewal is going to include some preclinical work on psychedelics. So let's see. Marcus, did you have a comment?
Well, I mean, I'll just say, to follow everyone here, we need to open up so much more research immediately, and we need to reschedule these drugs. Right now, again, we're being overwhelmed the amount of inbound individuals, not just from the U.S. now, but across the world, that are looking for access to these medicines. And yes, Dr. Volkow, we have to be very careful of how this rolls out. We don't want another Tim Leary episode to ruin or derail what's happening in this space. But there are people committing suicide. There are individuals looking for access, and as long as we take the proper care and proper approach to accessing these medications, and again with the proper mindset going into it, in the proper setting that Dr. Yehuda can talk about all day, we just need to find a way to have access to these medicines, and whatever that is opening up research and rescheduling them.
Well, I guess we only got to one question because it's the top of the hour. There are a number of other ones. For example, 2A or not 2A. That's the question. But we'll try and answer those in the chat. And thank you so much. This was really an enlightening, informative, and exhilarating briefing. So it was great. And be well to you, to the panelists, and to everyone else who's listening. Thank you.
Mark, thanks a lot. Terrific. Thanks, everyone.